We are going to go ahead and get started. So I'd like to introduce the next panel, Implementing Connected Health into the Real-World Setting. We'll hear from a panel of leading experts who will talk about how they're applying technologies to their strategies to improve the cost of care, health outcomes of experience and of the consumer. And the lead of this panel is Puopolo, who's the VP of Business Innovation at Highmark.
Good morning. I'm Puopolo. I'm the VP of Business Innovation at Highmark, and it's a pleasure to be here this morning, and it's a privilege to kick off the morning events with this distinguished panel. And today, we're going to talk a little bit about the real-world aspects of connected health. We've all seen the trends. We've all seen consumer trends with wearables. We've been told that there'll be 80 billion devices by 2020. That's 10 per person in the homes. We've seen the VC investments in digital healthcare technologies. We all have a sense that the consumers are going to be in the center of their healthcare and that the consumers are going to self-manage and they're going to share that real-time data with their care teams. And then we have reality. And reality is that utilization is up right now is up with the early adopters and that our chronic conditions are on the rise. 75 million people have multiple chronic conditions. Our eating habits are terrible. Fast food runs our couches and runs our cars and runs our homes. And so things aren't quite where we think they are. It's kind of like a bad date. You really want it to work, but it's just not working. It's not you, it's me, right? So today our panel is going to discuss some of these real aspects of connected health. How is technology going to help alleviate this tension that we're seeing between the vision of connected health and what's really working? And so we're going to try to tackle some questions around what's working, what's not working, who's paying, how do you scale? And so I'm just going to briefly introduce these folks. And then we'll get kind of into the questions. And I do want to make sure that you all get a chance to ask questions as well. So I'll be keeping my head up to see. I think there's mics on either side. So please jump in and ask questions. So first here on the list is Andrew Watson. He is Dr. Andrew Watson. He is the Vice President at University of Pittsburgh Medical Center. We have Lauren Cheung, who is the Medical Director of Innovation. It's of Strategy and Innovation at Stanford Healthcare and the Medical Director of Strategy and Innovation at the Department of Medicine at Stanford University School of Medicine. We have Rosin, who is the Chief Innovation Officer at Penn Medicine, and Dr. Mark Smith, who at MedStar, who is the Chief Innovation Officer at MedStar Health and Director of the MedStar Institute for Innovation. And so I'm just going to let them talk a little bit about what they're doing and their role is with connected health. And then how are they applying connected health in their particular organizations? So why don't we start with Mark on the end? Do you want to kind of just give us a little bit of background on what you're doing and
Sure.
how you're applying it?
I'm happy to, Paul. Thank you. Good morning, everyone. So my name is Mark Smith. Spent most of my professional life being an emergency physician and having responsibility for both working clinically and organizing emergency departments, which has grounded a fair bit of my experience in this current position of Chief Innovation Officer. MedStar Health, for those of you who are not familiar with it, is a large not-for-profit healthcare system in the Washington-Baltimore area. It started, like many healthcare systems did, as a collection of siloed acute care hospitals, and is now trying to remake itself into a more of a platform of care, distributed care delivery network. It is definitely the real world. I say that if something works at MedStar, it'll work anywhere. We're a sort of microcosm or fractaloid of the type of care delivery systems, rural, urban, suburban, indigent, middle class, wealthy, academic community, and so forth. So I'm in charge of this organization called the MedStar Institute for Innovation, and the way how we fit into the connected health space is the following. Our mission is to catalyze innovation that advances health. 5 words. And that's pretty broad, and it's actually, it's pretty much a carte blanche to move in to try to look into areas of white space and try to help MedStar and hopefully other folks get us there. So connected health, the whole information space, is obviously one of the things that's going to enable this incredible transformation of that's occurring in Titanic transformation occurring in healthcare right now, from this pay-per-view, fee-for-service model to a subscription service, bundled payment, or in fact just a single payment, and moving from treating acute ill and injured to managing chronic illness to actually dealing with health and wellness. In some sense, we're changing ourselves from being a disease care system to a health care system. And what do? We're catalysts. We are in between the operational piece and the great ideas and the outside world. So we have technical capability of helping prototype new care delivery experiments, some of which are in the connected health space, and we also, which I'll talk about a little later, we are the portal for our organization into the outside world, into the world of startups and small companies. MedStar is a founding partner of a group called 1776, which is a incubator seed fund in Washington, D.C., which is just basically started in education, health, energy, and transportation, and has now gone global. And we've been exposed to huge numbers of companies that we brought in and worked with within our organization, many of them in the connected health space, you might imagine. And it's really infused an enormous amount of this startup, we can make a difference energy that standard healthcare needs so desperately. So I think I'm going to stop there, and we'll pick it up in the next round.
Thanks, Roy.
Sure. I'll just say ditto. So, Roy Rosin, I'm Chief Innovation Officer for Penn, and I don't have a clinical background. I spent most of my career out in Silicon Valley at Intuit and working with startups, building technology businesses. Let me start maybe with a quick definition. When I say connected health, what do I mean? And we actually have a definition that is distinct from telehealth. There's no one right definition, and one is not better than the other, but for us, when we say telehealth, that basically means remote delivery. So FaceTime, Skype, et cetera. When we say connected health, what we're generally talking about is knowing and seeing things we never knew and saw before at different times and in different settings so we can act on those things. So this is the pill bottle talking to us, the scale talking to us, the blood pressure cuff talking to us, et cetera. And we can talk about very specific examples of that. And so, we got a gift from Secretary Burwell at the beginning of the year, who starts talking about how the Medicare payments are going to change, by 2016, by 2018. And it kind of just reinforces for Penn as an academic medical center that while we may not be an ACO or a fully accountable organization, we are taking on more and more risk-bearing contracts. My organization we do a lot of things. We basically work with teams across the system to enable them to test and experiment with novel interventions and start to scale those interventions that work. But we love de-risking future models. So anytime we have a chance to look at these future models and apply the intersection of technology and sort of humans to those models, we have a really good time.
Great. Lauren?
Great. Well, thank you. My name is Lauren Cheung. I am here filling in for Sumbul Desai, who is the Associate CMO of Strategic Innovations over at Stanford Healthcare and also the Vice Chair of Strategy and Innovation in the Department of Medicine at Stanford School of Medicine. So I will also start with our definition of connected health. And so connected health to us is really what we mean, or we say connected health when we look at any of the multitude of ways that we can deliver care leveraging technology. And so whether that be telemedicine, mobile apps, devices, it really comes down to the patient experience in ways to improve the patient experience using technology and creating new ways of delivering care. And so what I've been involved in at Stanford, there's both the hospital side and the university side. So on the hospital side, I've been involved heavily in the creation of our telemedicine strategy and also the design, implementation, and launch of telemedicine across all of our clinics, including the design of our newest clinic, which is our virtual primary care clinic, which I'm also a practicing physician in. On the school side, we are really looking at ways to evaluate and implement new technologies or new digital health technologies into the health system. And so what we have recently done is we've created a new digital health center. And that digital health center will focus on strategic advising as well as clinical trials, and we'll have an innovation fellowship to really center all of the work that we do on connected health and digital health.
It's a pleasure to be here. We're going to loan Dr. Kavita Punxsutawney Phil next year when he schedules the conference because of his weather predictability capabilities. Because I know if last year, too, there was an incredible storm that blocked us from coming here. My name's Andrew Watson. I'm an actively practicing colorectal surgeon, and about 90% of my time's on the corporate side of UPMC. And if you don't know, having this gentleman and I sitting beside each other on the stage is like having the Hatfields and the McCoys hold hands. The Pittsburgh landscape in healthcare is actually quite remarkable. But UPMC is a global healthcare company, and we have an interesting perspective, like Highmark does, of paying for healthcare, delivering healthcare, and we also have a global aspect of what we do as well. And when you look at connected health, or telemedicine, or telehealth, or e-health, or e-care, whatever the word is, it literally is the collision, as we see it, of the consumer electronics market with healthcare. This is a new era that we live in right now. We used to live in an era of nuclear fear. We lived in an era when we were at farms. We lived in an era of industrialization. This digital era started in the mid-200s. I'm not sure, mid-2000s. I'm not sure what had a greater impact on our society. Was it the iPad or the iPod or 9/11, because they were about 2 months apart? In this digital world at UPMC, and we certainly see for our members and our patients, that there is a tremendous potential for using the digital world to take care of them better, communicate better, manage them better, and also prevent in a much more effective fashion. So for us, our focus is really on this whole binding together of these two very powerful forces of the need to take medicine back to its roots, the homes, the patients, and the communities, and also use the life ring that the consumer electronics market has thrown us, which is the ability to reach them, enable them, and communicate with them. So our focus right now is in a couple very key strategic areas. We invested a tremendous amount of money in the last decade or so in our infrastructure, the core of it, and now we're using it. And the focus is on patient portals. There are companies out there like Doctors on Demand and American Well. We're also looking at remote monitoring, something that I lead for UPMC, which is the whole biosensor feedback engagement world coming into the front lines of medicine. So for us, we view telemedicine as a core component for the delivery side and a growing component for the payer side. But as an organization, we view these patient portals and remote monitoring as some of the most powerful forces in healthcare that we've ever seen. And a lot of this comes down to making sure the operations of your healthcare system and the cultural change are aligned. And that's probably one of the greatest challenges that we've ever seen. But it's a real honor and pleasure to be here. I speak around the world and travel a fair amount, and I think this is one of the best conferences I've ever been to. So it's a pleasure to be here and an honor in front of you folks.
Great. Well, thank you for the background. So let's kind of get into some of the questions. And operations seems to be a topic, and I don't know how many of you out there are trying to think about connected health, and then what do you do in these large organizations? So one of the things I want to ask the panel is, who does connected health, right? Nice that all these technologies are out there. Nice that all these startups are knocking on our doors, right? And then you look at your large organization and you have to say, who's got this one? And do I need an innovation center, or do I need a digital health center to manage this? So Roy, maybe I want you all to kind of chime in this, but I'll start with you on what's the sense of organizing around connected health, and who gets it in the organization? Is it IT?
Yeah. So, it's still a very distributed system at Penn. So what I'd call is lightweight central coordination right now. Our CMIO, Dr. Bill Hansen, and some leaders from our IS organization and I have kind of gotten together, and we have a connected health group that meets for sharing lessons learned, and there are quite a few lessons learned on everything from technology to licensing to everything in between, and starting to make decisions about investing in core platforms and core capabilities that all people who are working on connected health need. We have an interesting situation at Penn in that there is this platform called Way to Health that Drs. David Ash and Kevin Volt built. It has over $30 million of NIH funding behind it, and it is it's at the intersection of connected health and behavioral science, because one of the things that has become pretty clear to us is that it's kind of like, big data or data science. Knowing is not the goal, right? So connected health can make us aware of a lot of things we didn't know before. We can follow people home from the hospital, still see what's going on, et cetera, or before they ever get to the hospital. But it's all about behavior change as well. So we needed to make sure we had the tools in place to apply behavioral science around behavior change. So once we know, we have to design an intervention that does something about the fact we have this new data now. So we are starting to make central investments in a platform that multiple people could use in many different ways. So organizationally, I think it's still mostly coming from the practices, coming from the individual investigators who see an opportunity, and that's quite a few now. You see it increasing. The more bundles and the more alternative payment models you see coming up, the more people say, gee, if I'm going to get good at that, I better know what's going on with this patient in entirely new ways. And system-wide, we're starting to really pay attention to things like GPRO, the group practice reporting. So all of a sudden, you need to know that your hypertensives are in control and that your diabetics are in control. So again, the ability to have more information and to see and detect things early has become a systems issue now, not just an individual physician issue. So we are putting central infrastructure, central components in place, and we are starting to talk about what works and how it works. I'll tell one quick story, though, to end on the, just to give a very specific one so it's not abstract. One of our best connected health interventions that we've done so far actually had to do with congestive heart failure. And we're not unique in this. Geisinger and Harvard both had very similar types of interventions. This is, again, following somebody home so we know once they're there, what's going on with them. If you could be with that person 24/7, what would you want to know? Well, have they gained too much weight? Are they starting to cough? Do they have a swollen belly? All the things that might mean you need to do medication titration. And it was a perfect pilot in some ways. So this is now a product called Right Care Solutions. This came out of our incubator that we do in Philly. But the thing that was fascinating is after this pilot where we had 0 preventable readmissions, and the chief medical officer and everyone said, this is fantastic, we should invest and scale this across the system. Nothing happened. Months go by, nothing happened. A year goes by, nothing happened. And everyone thought we should do this, and yet there was no organizational structure to actually make this core to the way we did our work, to go from experiment to a scaled intervention. What ultimately happened, and I'll end on this point, so the others can put in their points as well, is that we had to create the structure of a service line. We had inpatient, people focused on inpatient, and outpatient, people focused on outpatient. The way we had done the pilot was sort of we had done essentially a fake back end, an experimental method where an inpatient group did something that was non-scalable. They followed the patients and they had to run and scramble and find the people who could do the medication titration in the outpatient world until it was someone's job to make sure we kept that patient healthy and out of the hospital, which is what the service line became. The greatest technology in the world didn't really matter. The organizational structure had to be there. So we're paying a lot of attention not only to the technology but to the structure, make sure someone's there to catch and it's someone's job to achieve the outcome that the technology is meant to achieve.
Others? Want to comment on how you're organized or how you're managing this from an implementation standpoint and a scale standpoint when you know you need to go there? How do you even start, I guess, when you're a large organization?
So I would say, so at Stanford, what we found is that it's been really essential to create kind of these multidisciplinary teams right from the beginning. So at Stanford, our organization is split into kind of 2 separate but collaborative units. So the clinicians are organized under the School of Medicine, and the hospital and clinics run under a separate system, which is Stanford Healthcare. And they really do operate as separate units. And so oftentimes what we find is on the healthcare side, if we've got administrators, because we have a group, so a digital health team managed by hospital administrators there, if they try to bring something over and force the clinicians to use it, there is a large amount of pushback, and it almost never happens. And so what we found the best model is to really focus on creating these collaborations across the health system, so with the clinician as the champion for the most part, and then collaborating with the ops team, with the IT team, to drive an initiative forward. But we also have found that you really do need that clinical input, because without it, you're not going to design something that clinicians want to use. You probably won't design something that patients are going to be as likely to use. But if it's the clinician alone trying to do it without the help of the health system, we've encountered the same thing, which is that we just can't scale, and an initiative just won't move forward.
Great, great. So let's just shift gears and talk about challenges. And Mark, if you want to add.
Can I make one comment about the operations?
Sure.
I'm just curious in the audience here. I know how many people here have currently practice telemedicine? Could you raise your hands or have experience with it? That's it? Okay, come on, hands up. How many people have a program that's greater than 5,000 people a year? The challenge is some of the biggest programs that we see are organizations like Avera in Sioux Falls, South Dakota, and obviously Ed Brown and the Ontario Telemedicine Network has been a role model for the world in terms of telemedicine. And I completely agree with my peers up here. The challenge of this is not IT. We now get lured into the appeal of the IT. And right now, my God, we have phones that have XLTE. Who here carries more than 2 cell phones? Oh, come on. I know some of you aren't telling the truth. We have 2 cell phones and a computer and frequently a tablet as well. It's the norm that we have. The challenge in this world that we live in is that the technology is approximately, we think, about 20% of the challenge. The real issue here are operations and finance, of aligning these for programmatic development. And that's hard. We're going through a very large process of re-engineering our remote monitoring program, and what you realize is you're slowing down the hospitals and doctors. And if you want to walk into the CFO of the hospital's office and tell them that, go for it. And so there's an enormous cultural change, but an operational hurdle to make sure that when telemedicine happens, you have the financial models built at scale and also the operations there to support it. The technology these days has really faded to the back, but it is the most alluring part of it. And that's one of the things that we're seeing persistently. And if you want a tip, the easiest way to advance this cultural change is to look at the risk-bearing entities of your hospitals. If we're on the hook for readmissions, if the payers are on the hook for chronic disease management, if the medical homes are on the hook for quality measures, those are the areas of looking at a risk mitigation strategy through connected health and these telehealth initiatives. And that's the fastest way to win the hearts and minds of people, because you're hitting at the core of operations and finance together. It's a bit of a noble journey, so wear some Kevlar in the process, but it's worth it.
Mark?
So I want to concur with what Andrew said about it's the non-technological parts. And we're like at MedStar, what Roy said, we're both, it's a distributed thing. Some things are going top down, some are going bottom up. So if we're trying to do an e-visit program, which we've just started with American Well, that's going top down, required corporate to vet a number of the vendors, and then we picked on one, and now we're experimenting, we're trying it out on our own staff, because that's a captive audience, and then we'll scale that up. One problem we had with that was that this is a system that where the doctors, American Well has its own physicians, but we wanted to have our physicians doing it. Well, who are our physicians? Where is the empty space in their schedules, and how do you reimburse them extra? It becomes, there's a lot of very, very practical, tricky questions to make these
Isn't that
work.
fun? Isn't that a fun discussion?
Yeah. On the other hand, so that's the top-down stuff. But the part that I find, and that's adaptable infrastructure. And what I like about it is you're putting infrastructure in place that you can use to address or solve problems that you don't even know exist at this moment. And so we all try not to build a series of one-offs, but try to take a one-off and seeing what greater whole it's an example of. The interesting ones in my mind are some of these bottom-up ones. I'll just give you 2 quick stories. One is, which illustrate a principle of unintended consequences, things you think are going to be important aren't, and things that you had no idea were going to be important or valuable are. So one of the 1776 companies that I had, the startups, is a company called 1EQ. They do blood pressure and weight monitoring for OB, for patients who are pregnant. It's an early warning system for preeclampsia, but it's also a connection to the OB practice with nurses. It results in fewer visits, so you can fill your schedule more since it's a bundled payment. They like the OB department likes that. But we had no idea that the patients were going to feel all of a sudden that they're getting concierge service, that they have this tether line, and that was an unintended consequence. That came up, and another one we found a company called Capture Proof, which solves the image issue. So just a tiny digression. One of our rules is if you want to look for where to innovate, there's a number of different principles. One is look for something that hasn't changed in 40 years. It's either a perfect design like the safety pin or the paper clip or the Stanley Power Lock tape measure, or it's crying out for innovation. And one thing that hasn't changed in healthcare is how we document care. It hasn't changed in 90 years. We use words. The rest of the world, written, typed, pick listed, the rest of the world has now moved on to pictures, stills, and videos. And so we found this company, brought them in, exposed them to a number of different groups within our organization, and now we have pilots planned with the VNA for following wounds, patients taking their own picture, and with our rehab center for post-op hip rehab. So there are these little niche things we kind of weaving a patchwork quilt together, but we are getting to building a kind of full blanket.
One thing I might say is that I'll take one more minute on challenges because I want to give some that are specific to connected health as opposed to telehealth. So going back to again, our definition of connected health being the sensing and being able to act on things. So the first thing I'll throw out there as a challenge is expectation setting. I think a lot of people say, oh, we're going to take better care of people and get much better outcomes. And the reality is the first thing that happens, if it's working, is your costs go up. And the reason your costs go up is you actually discover things you should have known about all along, and now you have to do something about those things, right? So there's a up before there's a down, or maybe in your direction this way. And that's really important for programs, because if the first thing everyone sees is actually everything moves in the wrong direction, they may not stick around for the long term, which you may need them to. So expectation is really important. The other one is, so things don't work out of the box. So we had done a similar pilot. Preeclampsia is the #1 driver of maternal readmissions and morbidity, mortality. And we just did a basic texting intervention, sent them home with a blood pressure cuff and text. Very simple, using, again, a human, a non-scalable back end to do some experimentation. We had to get through 6 or 7 iterations of this. So it's not the technology necessarily, but you learn all these things by trying. So again, you have to understand, I'm going to structure this to understand the people, the human side of it. It's really, I think, extremely important. And then finally, the behavioral science element that I do want to come back to. Just to drill down on the comment I made before, I was at a big data conference in the early days of big data, of extracting value from large data sets. And once you have the brilliant people who can do the algorithm, which I'm not one of those brilliant people, so this is not easy for me, but that becomes the easy part. Right? The hard part is, okay, now I have this information and I have to act on it. I need to do something about it so I change the outcome. Right? Again, it's not about knowing, it's about acting and changing. And so, when I look at our most successful programs, we have one on medication adherence where David Ash and Kevin Volp, again, using the platform, have doubled medication adherence now. Right? This is not just the wired pill bottle. It's not just getting information about whether people have or have not taken the medication. Again, it is using some other things like social support structures, using financial incentives, saying, okay, we're going to have a very intentionally defined lottery here that actually influences the engagement of the folks that we're targeting. So I think there's a mistake, again, and I think my peers up here have said it quite often, it's not just the technology. It's all the human behavior around it becomes a real challenge. And if you don't address those things, you can end up with lots of new data, and you're not going to end up with different outcomes.
So let's go in that direction a little bit more then. So I'd love to have faith, right, that we're all going to manage our own health, right? I'd love to have the sense that Americans, we're all going to get on board and we're going to use our apps, but I'm a victim of, I've got 3 fitness apps on my phone and I've used them for 2 weeks, and I used to wear the Up Band and I threw it away after 3 months. Clearly it's not the technology that's available. And we saw the ecosystem this morning where Joe put the ecosystem out about where we need to go. How much is I call it the provider, the doctor, the physician involved in this? And can you give us some of your opinions? Because Lauren, you talked about patient experience. In order to get people to do it, where does the doc fit in? And then how are you guys handling that within your organizations? And Lauren, maybe start with you, and then Andrew, maybe from your experience because of UPMC and the big system, where you can comment.
So I will say that I am very skeptical about self-management and complete self-management. And so coming from Stanford, you know, I'm in the heart of Silicon Valley, which is pretty much the heart of the quantified selfer. And what we've found is that patients really don't, or the consumer is not going to use a device for very long if it's not connected to the provider. And when I say provider, I will actually expand that to not just the physician, but also to your ancillary staff or support staff that you're using. So one of the examples that we have is, so we started a virtual primary care clinic, which is essentially a primary care clinic where we take care of patients online as much as possible. So email, phone, and video visits. And integrated with that, we also offer wellness coaching done virtually. And as another part of that, we offer connected devices. So patients can send their information into us through their smartphone, their smart device, and that's vital signs like blood pressure. Well, we found that patients really, really value that relationship they build with their clinician. And without it, they're just less likely to use those devices and those kind of technological tools. So we found that, for instance, our wellness coaches, if we recommend wellness coaching to our patients, the engagement and adherence is extremely high. They love it. They love being able to meet with their wellness coach virtually. They're engaged. They like that relationship. If I recommend a connected device, if I say I want you to check your blood pressure, we've found that they might check for 2 weeks, and then after that they stop. Even if they get a message from me, it's just that they will not continue to do it. And they're less likely to, you know, even if after they've checked for 2 weeks, if I continue to remind them, hey, I'd like to get your blood pressure from you, they're just not as really taken with the idea of doing it. And I think that's because of the difficulty with doing it, and they don't see the value. So we agree, I agree with everything that's been set up here, which is that technology as the focus of your solution is really not the way to look at things. It's really, how do you design a care model that looks at how the patient and the provider wants to use technology, and then develop a solution that works for those populations.
And Paul, it's an excellent question. What is the role of the physician? And let me just couch what I'm about to say. I'm a fourth generation surgeon, the seventh surgeon in my family, so I love physicians, and my wife's a doctor too, and she's a cardiologist and keeps me healthy. There's two roles that the physician have in this new ecosystem, and I agree a lot of what my peers are saying up here. Number one, there has to be a benefit to us, and I say that not in a selfish way. And number two, that our cognitive understanding of this world has to evolve extremely quickly, and I'm not sure we're going to be able to do that. How does it provide benefit to us? I couldn't make this story up, but I'll tell it anyway. I was in northern Norway in a town called Buda at a Stone Age dinner where my dinner was being dug out of the ground with a moose scapula, having been cooked underground for 4 hours. And I got a call from UPMC Horizon. I got a text message from one of my key referring physicians about a Crohn's patient he had in a rural clinic. So on my iPhone, just regular, whichever one it was, I picked it up and on a 3G network looked at a CAT scan that was in a federated environment at a rural hospital, saw Crohn's disease, fistulizing, multiple loops of the terminal ileum, some inflammation, and I was able to actually call that provider back who was in that rural clinic, give them the advice, put the patient on basic ciproflagyl. I see them next Thursday. We'll operate in about a month. So it prevented that patient getting flown down at an enormous cost. The payers don't like that. And also it gave the patient the confidence that he had a connected environment around him taking care of him. It provided direct benefit to the patient, to both sets of physicians, to the hospitals. It benefits us. And so if you look at telemedicine, if you look at maternal fetal medicine, if you look at dermatology, you look at post-acute care, I've only done about 500 consults myself, but there's a real benefit. It's less travel to me and my patients. So for us, the benefit to the providers we have to leverage to the max. On the flip side, I don't know if the physician community can evolve fast enough. I just don't know if we can do it, and I don't know what's going to happen if we don't. If you look at the professional societies, all of these large colleges of radiology, surgery, GI, cardiology, I'm not sure where they are with all of these issues right now. And if you look at the physician community, we said no to hand washing with Lister. We said no to antibiotics and Fleming. We said no to DNA, transplantation, laparoscopy, EHRs. I love being a physician, but we simply cannot say no to this, because what we're discussing here in this panel is the consumer electronics market and the consumers. We could say no all we like. It has no bearing on what's going to happen. We cannot slow this one down. So my greatest fear with the physician community is how we cognitively evolve and who's going to broker that. If it falls to the hospital level, which sadly I think it's going to, these hospital CEOs are in food and water mode with 2 and 3% margins, struggling to get these capital and other infrastructure problems up. They are not able to handle or broker, nor should they, that cultural change. So for us as the physician community, I don't know what's going to happen. And I work at the national level. I was just in Norway last week again. We're having the same things over there. We see this. I don't know if we have a community can catch up to where the consumers are. And so it really, in some ways, our opinion does not matter. But the efforts of my colleagues here in this panel are spot on. We've got to get this aligned so we see benefit, and also to just send out a warning signal there is a tsunami coming. And it's the real one, this one.
Is there, I'm looking out to the crowd. I'd like to take some.
I was going to add one real quick thing to that. I mean, one of the benefits, it's very important, there's a design principle that you have to manage, which is this all has to be exception handling. And because I think Andrew's absolutely right. One of the ways this can happen is you're swimming in more to do and more data, or this can actually reduce overhead and reduce workload. And the best connected health systems are designed for exception handling. I only need to pay attention to certain people, and I cannot pay attention to a whole bunch of other people. So there are truths across the board here, right? I mean, I think Stanford was the first place that did the basic research that showed that if you give someone a pedometer, they walk more. But the reality is that doesn't change health, because that is, and I think you said it well, it's a very specific segment. If you're at the tip of, the high end of super utilizers and frequent flyers, there is no app for that, right? I mean, these people need high-touch interventions, and you see high-touch interventions starting to make a difference, many times supported by, the underlying technology. In the kind of the core chronic illness, which is 75% or so of the problem that we're dealing with today, some of these people have the means and the engagement that they can actually have some self-efficacy, but certainly not without also human support and human touch. And when you design these very intentionally, right, if you take that congestive heart failure one I said before, we're getting these feeds in. You have a dashboard, you're sitting on the side, and instead of the nurse having to call every single patient to check in with every single patient, now she only has to check, or he only has to check, the 2 that are flagged as red because that person gained 4 pounds since yesterday. So now it is an exception handling type of approach, which does have a benefit to us from efficiency. As the world moves towards population health, the ratio of patients to physicians is going to go in the wrong direction, if you will. So we have to get better. We only have so many physicians, and we have to get better at doing really good work with a super light touch and focusing and changing how we spend our time. So we can allocate our time to the people who need it, and that will work.
Great. We have a question.
There we go. Mic's on. Good. My name is Mitch Mitchell. I'm with McKesson. I have a couple of questions. And I didn't catch your name, I'm sorry, from Stanford, but I have a question about your virtual clinic. Are you doing any research on the relationship with the provider as being sort of that secret ingredient that makes all of this come together? And if so, is it done? What's the timing on anything like that? Are you digging down into that a little bit more?
Yes, so we are absolutely doing research. We are doing research on every single aspect of our clinic. It launched in January, and it's for our own ACO population, which is a nice thing because it lets us study a closed population. And what we found is that we've done a really good job of training patients to get care. As a society, we've done a really good job at training patients to get care in traditional care models. So their acceptance of moving to something like telemedicine for their care has not been really what we expected it to be. So what we're finding is there's a split between new and return patients, but we've got about 70% of our new patient visits are done in person, even when the patient's given an opportunity to do the visit virtually, because we know based on their complaint or what they want that we can get it done virtually. Moving from there, for the return patient visits, we've seen that I think about 60% of our visits are now done virtually. And that's about 30% of all return visits are done through video visits, and the other 30% are done through phone. Compared to if we look at the wellness coaches who only operate virtually, and we're seeing that about 70% of their visits are video visits, 30% are phone. And so, and then we look at connected devices, and I would say whenever I prescribe a connected device, I get maybe, 5% of them using them. And whereas if the wellness coaches who have that one-on-one relationship with the patient, they're interacting with the patient much more frequently than I am, and giving them active feedback on what's going on, they're getting better uptake of connected devices than I am. You know, the doctor who sees the patient only every once in a while.
Data on your website?
We have a paper coming out soon,
Okay.
but it's not up on our website.
Okay.
I'm sorry, I didn't mean to cut you off, but you got 5 minutes. I want to make sure I get the people behind you.
Now
Is that
there's
okay?
a line. Okay. Maybe just a real quick chime in from everybody. How large are your groups that focus on the non-technical, the change management, first? And then two, where are you spending money? And are you spending money to outsource that role to help drive change management by either staffing it internally, relying on the vendor, or seeking outside help? So how big are your groups, and where are you spending money to affect the non-technical piece?
Group is small, not spending money.
Very hard to quantify, but very interesting.
We just set up a center for influence and rapport in health to try to deal with this, look more carefully at this relational dimension. Everyone's focusing on the technology and on the transaction part. So it sounds like it's a theme that's been echoed. It's small, but what's interesting is that it is getting requests from all over the system. People are very hungry and recognize at the end of the day, we are humans, and we need and crave connection to other humans.
Question? I'm sorry, Lauren. I didn't mean to cut you
Oh,
off.
I was just going to echo that.
Go ahead.
We're really small.
Hi, David. Thanks for coming. This is really helpful. I'm a psychiatry resident. I run a startup in the mental health services that's funded. Quick question. So you mentioned that even if we run a trial with either a payer or a provider and it shows great endpoints, it's still hard to scale. And you chalked that up to a lot of organizational issues. So what are on-the-ground advice that you would give to startups or mid-sized companies that try to interact with these large payers and large organizations?
I think some of them have been said. Let me be as explicit as I can in this one. So one is defining how good is good enough up front. Like, what does success look like? You need explicit graduation criteria to go from pilot to something scaled. So that's one. Second one is you need to understand who will catch, who will operationalize this. You have to move them as far upstream as possible. I mean, I know that's trite. Yeah, that gets talked about a lot. But you know, I did the pilot. Now I'm looking to throw it over the wall and have somebody fund and scale it. Not going to happen. They weren't part of it. They don't have an ownership, and they can't really take credit. And you want to make them a hero, if you will, in the organization. You know, third, and I know some of the peers up here said this already. When you're doing change management, you want to start with the converted. You never want to convert the unconverted, which means you're looking for existing momentum, right? You're looking for where people are pulling. If you're pushing, forget it. It's not going to happen. So go with that momentum. Find the folks, whether they have risk-bearing contracts or otherwise, that they have a reason and need for what you're doing, and make them a hero. Lots of communication, lots of kind of visibility around the measures, and always be asking what case needs to be made, right? You know, what is it you need to see by the end of the pilot? The number of times I've seen, I work with startups a lot, and the number of times I see a pilot and they get to the end of the pilot and they say, hey, what's next? You're already dead. It's kind of too late. You have this gap, you have to think about contracts and contract cycles, and we didn't set it up for the kind of evaluation we need. So while not everything we do is in the old RCT, must be gold standard research, it has to be vigorously evaluated so does this in fact make a difference, and what made a difference, right? So those are the upstream things.
And I'll add to what Roy said. I've been impressed with the discipline methodology of the whole lean startup, and impressed with how, say, a incubator like like the one we work with, 1776, can actually help startups look ahead and don't come to a spot and then say what next. So it's all about scalability and sustainability, and it's from the very beginning they are thinking in those terms. So my answer is you need some outside help for that, and you need organizations that you don't spend any time trying to convince you of something that's good for them. As Roy said, people have a problem that you're the solution for. That's the kind of energy you want to be in.
I'll be very brief. When the bank robber was asked why he robbed the bank, he said that's where the money is. Look at the people that bear risk. If they bear risk, they'll be interested. Cognitive behavioral therapy and virtual behavioral therapy is critical for the medical homes, the rising risk, the dual eligibles, and the like. Those are the folks that need it. So if they've got it, they've got to manage risk, and behavioral therapy is critical. Look at Peter Yellowlees, too. He and I are on the board of the American Telemedicine Association together. His work in this field is spectacular. He's a true thought leader. Yellowlees is his last name.
Thank you.
And I'm going to squeeze in one last question.
I'll try to be quick. My name is Angela Nguyen. I work for the Brigham and Women's Hospital, and I also work on telemedicine. And this question is more so for Dr. Watson and Dr. Smith. I think you guys touched base on it. So I feel like when it comes to telemedicine or e-visits, providers who are interested in offering these, they're very engaged. But it's in practicality, it's really hard to find the time in their clinical schedule to offer this. So I was just curious, at a high level, what are some successful approaches or tactics or strategy to overcome this kind of change management barriers?
This is a big challenge, and just so you know that these e-visits can be done by APPs and physicians. One of the real leaders is also Glenn Hammock in telemedicine at New Physician and UTMB in the prisons back in 2007. And he's got a very good point. It's Ghostbusters. Who you going to call? A patient says, I have a sore throat. Who are you going to call? Where do you find that provider? The only logical way from an operational standpoint is to have physicians that are sitting there, like the Maytag repairman or woman, waiting for a consult. Running a blended clinic is a highly evolved situation. I run blended clinics now in my surgery clinics. I'll see physicians in multiple locations. Patients in multiple locations. You're going to have to pay for a series of physicians to be available in scheduled blocks for those visits. I would not recommend running blended clinics because you're never going to solve the Ghostbusters problem. And if you make the virtual patients wait, it's going to have a major problem. You just got to pay for it, and that's a challenge.
I'll just say I agree with Andrew.
Can I add something to that? I think also that you can think of innovative ways to staff. And so one thing that we did in our clinic is our physicians are salaried, so they're there for our primary care patients, whether they want to be seen virtually or in person. But what we also did was that we co-located it with our urgent care clinic so that we weren't sure what the volume was going to be. And so when our physicians are not busy seeing our own patients, they then move into the urgent care center and see any walk-ins or any other patients that don't coincide with virtual visits on our own schedule.
We tried that and found that it did not work, and we actually had to we're bringing on a second physician whose primary responsibility is the virtual visit, and the secondary one, when they're not doing the virtual, maybe they can sneak in a real patient.
I agree with that. They don't have the primary responsibility of being the only urgent care doctor there. They're really, let's say we have 4 urgent care providers. They're there as backup in case the urgent care becomes overwhelmed. If they have the bandwidth, then they can actually help pitch in.
I just say don't underemphasize or underestimate the value of redesigning the care model. And pretty much every time we do it, we try to design. You hear all the time top of the top of your license, et cetera. The reality is, like when we're doing like the medication adherence and there's a social support element, I said, the first support reminder goes to the next door neighbor, the grown child. Right? The physician gets it last. When we're doing it in a hypertension setting where we're trying to get people to be normotensive, you're designing the intervention model, the care model that leverages, in that case, like a Twine Health or a connected health platform, where the physician is the last person who gets involved. So we're trying to make sure that we are designing, leveraging this technology, but designing it such that we can pull new people in. When do you use the community health worker? When do you use the paramedic? When do you use, the nurse practitioner? When do you use the resident, et cetera? And so we're being very intentional about that. There are only 24 hours in a day. You can only see so many patients. You're trying to shift as much of the work to the lower cost person, the lowest cost person who can do it really well.
Yeah, it's the practice at the top of the license. It's sort of the reverse of, don't send a boy to do a man's job, don't send a man to do a boy's job, don't send a woman to do a girl's job. Have it be the lowest, have a hierarchy there. That's the only way we're going to get efficiency out of this.
Our time is up. I appreciate all your attention in this morning. I'm sure the panel will stick around and ask more questions, but join me in sharing your appreciation for the panel. Thank you very much.